Hello, this is Eddie Barnett here. This is a summary of a conference day on type 2 diabetes about the 16th of May. It was to be presented at our peer group meeting, but we didn't have time to do so the other day. So I'll just record the main details now. The specialist from Tauranga Hospital with the unpronounceable name was there, and the presupposition for the meeting was that there is some evidence that early insulin use is, in terms of diabetes, type 2 diabetes, intensive treatment may improve outcomes. I'm not sure this is exactly the case, but the unashamed presupposition is that basal insulin will do the job, in particular Lantus, probably. And anyway, let's look at the evidence. Here we got diabetes is obviously a hazardous condition, as shown by the hazard ratios. Vascular disease, even cancer, and other causes are caused by the multiple metabolic changes that occur with diabetes type 2. The people with diabetes are overrepresented as hospital inpatients. In particular, you'll probably find Maori, Pacific Islander, and Asian are particularly so, especially because the prevalence of diabetes type 2 is 5 to 10% in Maori and 3% in European. So it's apparently the figures are going to explode, of course, as the years go by, and then probably another 20 years there's going to be another 40,000 diabetics or something in New Zealand. I can't remember the exact figures. So a 50-year-old diabetic dies on average 6 years earlier than a non-diabetic. And interestingly enough, as I discussed earlier, because of the multiple metabolic problems, 40% of that difference in mortality is attributed to non-vascular causes. I guess kidney problems would be high on the list. Certainly the cardiovascular disease risk itself is significantly enhanced by the combination of microalbuminuria and blood pressure together. That combination is 2 to 8 times more hazardous than as a combination in diabetics. Obviously, again, we've outlined that Maori, Pacific, or Indo-Asian people are much more likely to have diabetes. Interesting, 2 out of 10 Maori deaths in Maori are due to diabetes, so a huge problem in the Maori community. It's obvious that optimal disease management should include strategies that address all the cardiometabolic risk factors and blood pressure and lipids and lifestyle factors as well. So it's a real big job in terms of education, and in general practice it most often needs a good deal of teamwork. And the diabetes nurse being well, not so much a diabetes nurse, but even a nurse that's trained or interested in diabetes to provide that help in education, training in the use of the drugs and general lifestyle factors. The goal of the HbA1c goal is certainly less than 7, and the closer to 6, the better. It's not always achievable, and may not always be in some of your patients that you've got, but intensive therapy would aim for that type of level. HbA1c is not used to diagnose diabetes. The fasting plasma glucose or the oral glucose tolerance test is that. And for screening for diabetes, you want to add a fasting glucose to every cardiovascular risk assessment bloods. So in a normal general practice, rather than a walk-in clinic, one would screen cardiovascular risk status and add a fasting plasma glucose. Again, the figures is where we've talked about already. The fasting plasma glucose greater than 7 or 2-hour glucose tolerance test greater than 11.1. So you don't need a oral glucose tolerance test if your fasting plasma glucose is raised alone. Again, HbA1c greater than 6.5 or even lower is a predictor maybe of prediabetes, but it is not, as I said, a test to be used for the diagnosis of diabetes. Interestingly, HbA1c of 6 to 6.4, the bottom line, imparts a 10 times greater risk of diabetes mellitus. Apparently, it seems fairly obvious that there's significantly less cardiovascular events with those with a shorter duration of diabetes mellitus, absence of known cardiovascular disease. I presume it means those people that are intensively treated at an earlier stage. And there is a higher risk of mortality in those with higher HbA1cs and hypoglycemia or hypoglycemic unawareness, and probably, and also the one I talked about before is microalbuminuria and blood pressure together is probably higher risk for more sudden death mortality. The treatment of diabetes is initially type 2 diabetes, either metformin and sulfonylureas. Metformin is becoming popular again as a pretty safe drug. The risks of metformin have largely been largely exaggerated. One has to be careful, and obviously severe renal impairment or hepatic failure and alcoholism. But there is some. It is probably the first-line drug for those that are overweight, 120% ideal body weight, or a BMI of more than 25. So the figures are good. 32% reduction in the risk of diabetic complications. We'll go on. We'll talk a bit more about what treatment later and whether one is more beneficial than the other. Obviously, self-monitoring of blood glucose is important. Rather than someone doing it at the same time every day, we need to have people to, if possible, even in type 2 diabetes, is to do 6 to 8 tests on 2 or 3 days of testing a month, maybe, to give a more accurate picture of hypoglycemia in the early hours, in particular, or elevated glucose patterns in the day. Especially those people that are started on protophane, obviously. But self-monitoring of blood glucose allows feedback for patients, and sometimes helps modify behavior. A lot of patients do not meet the HbA1c goals, though in intensive treatment, this is what we're trying to do. Obviously, the whole package, as I explained, is important. The HbA1c is made up of the contributions from the postprandial glucose and the fasting plasma glucose. At lower HbA1cs, the fasting plasma glucose is a less contributor, and the postprandial glucose is the greatest contributor. At the high HbA1cs, the fasting plasma glucose is the greatest contributor. All HbA1cs are not created equal. This person has an HbA1c of 7.8, but he's slightly hyperglycemic at a couple of times during the day, but quite a different pattern from this patient, who has again an HbA1c of 7.8, but is hypoglycemic. The most worrying factor of this person is hypoglycemic in the early hours of the morning. which is not good. Of course, he's quite hyperglycemic at times as well. So this is where the frequent self-monitoring blood glucose will pick the pattern easier. Strict HbA1c targets may not be useful if people are having hypoglycemic episodes, or if they have hypoglycemic unawareness, and especially in probably older people and maybe those with poor social supports. So intensive treatment's not for everyone. Obviously, the meeting was all about adding insulin to type 2 diabetics as part of their regime. Basal insulin is probably the most effective first-line addition to the regime in terms of insulin therapy. And of course, you can use, the most commonly used is Protophane or Lantus insulin. Protophane probably overwhelmingly more common because Lantus needs pharmac approval. So we start by adding Protophane in at night and adding morning Protophane if necessary to provide basal insulin. The mixed insulins are probably not that useful in this situation. And again, obviously the glargine insulin, the Lantus insulin, has a wonderful record and much fewer episodes of nocturnal hypoglycemia, which is probably true. It's just not all that easy to get, and you actually have to pharmac document hypoglycemic episodes to get approval for that drug. As I said, one of the most important studies to evaluate the whole thing was the UK PDS study. This was a study that put 4,200 newly diagnosed type 2 diabetics randomized to receive conventional therapy or intensive treatment. Those randomized to intensive were further randomized to sulfonylurea or insulin, and the overweight ones were randomized to metformin. The HbA1c was 7 in the intensive group and compared to 7.9 in the conventional treatment group. But each of the therapies that were used for intensive treatment showed no real advantage over the others. That's was probably a point that wasn't emphasized at this meeting because they think basal insulin, especially Lantus, is the key. But the relative risk reduction was the same no matter what treatment was used. For every 1% reduction in HbA1c, there's a quite a marked reduction in microvascular disorders and microalbuminuria, less so for macrovascular disorders or overall deaths, though there was an improvement. So for every 1% reduction in HbA1c, there was an estimated risk reduction of microvascular complications of 37%. And between the three intensive treatments which with the goal to improving glycemic control, there were no major differences. Therefore, the UK PDS study concluded early insulin treatment didn't offer any major advantage over the other therapies in the prevention of microvascular complications. Okay, there's a couple of other studies. One study, the Accord, showed increased mortality in the intensive treatment population. Interestingly, this was explained by the Accord study having a longer duration of diabetes prior to starting the study. They were worse. They were higher weight, and they had hypoglycemic episodes they were in a grottier population, I guess. However, it shows again. It shows that intensive treatment should probably be as early as possible, and where it works primarily in microvascular complications. They went on quite a lot about some of the blockages to starting insulin, and there are patient barriers, weight gain, hypoglycemia, as well as physician barriers. Physicians may not have the time or the teamwork involved to get started a quite complex educational program. Some patients have the misperception that starting insulin means that they're at the end of the line, and in terms of early intensive treatment, this is probably the biggest blockage to starting insulin, and the biggest barrier in a way. Anyway, so the conditions for prescribing Lantus, which is obviously a good drug, there is no real peak. It's a pretty quick onset drug. It provides a very steady 24-hour insulin release. It's just that it's probably more expensive, and Pharmac, again, for type 2 diabetes, they require documentation of hypoglycemia. So that patient who had an HbA1c of 7.8 on Protophane has an inadequate treatment and and has documented hypoglycemia. That might be a good person to start Lantus on. It is important that, in summary, that metformin is not discarded as a treatment. In fact, it's becoming more and more popular, and especially amongst the overweight population. It's important that the HbA1c is intensively monitored and treatment tailored to get it to be as intensive as possible in almost everybody that you can, except for the people that have hypoglycemic unawareness, maybe, or poor social supports. And that intensive care of the HbA1c, or intensive reduction, even a 1% reduction, does seem to cause a significant decrease in microvascular complications. Teamwork is the most important thing in a practice. In most type 2 diabetics, after 10 years, they do require an additional medication or pharmacological intervention. So if they start off on metformin, they may need the addition of sulfonylurea and or insulin, or both. And that is apparently the intensivity that one aims for. Thank you.